Hello, welcome, and thanks for having us. Thanks to the American Acupuncture Council for welcoming us back. Always great to do these webinars. Very frequently, I do these with Matt Callison, who had something to attend to today, so he wasn't able to be here. We had kind of put this presentation together between the two of us, but in some ways, sometimes one of us does a little bit more work on one particular one or the other. So this one, I actually did a little bit more of the setup with. So if he's going to be out for a particular event, this one was probably as good of any, but it's always nice to have them here and do this together. But anyways, that is why I'm doing this one by myself. But let's go ahead and jump into the presentation. So what we're going to be presenting on is the psoas, major muscle. This is a particular muscle that a lot of people have interest in. It's a very prominent structure. You could consider it part of the core of the body, depending on how people define core. It can be one of the core structures. It definitely is a very core structure in terms of its stabilizing role on the spine. So we'll go over all of this in the presentation, but it is such a central muscle that we decided to focus on it. This particular timing, we are focusing on it in this presentation because we're getting ready to put together a little bit longer of a class, maybe like a 3-hour class, really much more of a deep dive into the psoas that'll probably be out for available on a webinar for CEUs later in either the year, probably more likely closer to the new year in January. So be on the lookout for that. It'll be available on our webpage. It'll be available through Net of Knowledge. So this is kind of the preparation for that. It's a little shorter version of it, and we're going to go into a little bit of depth in here and give you some ideas of how to work with this really important structure. So let's go ahead and jump in. So first of all, let's look at the anatomy. The psoas, in some ways, has two heads on the axial spine. There's attachments on the vertebral bodies and actually right into the intervertebral discs of L4 through T12. So that tells you something right away that this is going to be involved in a lot of spinal problems in terms of its centrality and how it's right up against those vertebral bodies with attachments right into the discs. But that's one of the heads, L4 through T12, but and that one's available in this image here. But if we were to kind of think posterior to this, if we were to kind of remove, if I had a little clicker and could remove the front surface of that psoas, we'd see its more posterior head, which is on the lesser trochanter, on the transverse processes of L5 through T12. So we have those two heads, which will be important in a second when we look at some of the neurology of this structure. But for now, just understanding that it really has attachments all the way up from L5 to T12, all the way on the lumbar spine, including lumbar discs, vertebral bodies, and the transverse processes. Then it sort of descends down. It crosses over the iliopectineal ridge, sort of over the junction between the pubic bone and the ilium, and then crosses and dives down towards the lesser trochanter of the femur. So that's the territory we're looking at. In the grayed out sort of portion of the structure, we have the iliacus. And as you see, and as many of you I'm sure know, that the iliacus has a common attachment on the lesser trochanter with the psoas. So sometimes people refer to as the iliopsoas, including that iliacus and the psoas. I personally like separating those muscles, even though they have a common attachment on the femur, for reasons that we'll get into a little bit later, both something we can see right now, and the psoas has actions on the spine where the iliacus doesn't. But when we start looking at the channel sinews and some of those relationships, it's nice to, in some ways, have those muscles in separate mental compartments so that we can look at the sort of channel relationships to them. But yes, a lot of times people will refer to the iliopsoas because of that common attachment on the femur. So that's the anatomy and that's the territory that we're looking at. So one thing to know right from the get-go with the psoas is it's intimately related with the lumbar plexus, and particularly with the nerves that come from the lumbar plexus. So let's look at this netter image for a moment and kind of get our orientation straight. First of all, on the right side, we have the psoas intact. So if you look at it by right side, I mean the illustration's right, the specimen's right. On the right side, the psoas is intact. And if you look at the left psoas, not only is it cut as you get a little bit towards L5, imagine you're doing dissection, and when Netter was painting this image, I'm sure he was going by a dissection model. So maybe they had already cut the psoas, and so we can see the iliacus deep to that. But more than that, on the left side, you can see that some of that more anterior head that attaches to the vertebral bodies and discs have also been cut away. And we can see right into the body of the psoas and see that the lumbar plexus is actually situated right inside the psoas, between those two heads, right there. Between those two heads of the psoas is the lumbar plexus and the nerves that come from the lumbar plexus. And this particular study I'm quoting here looked at dissections for 63 specimens and dissection, and 61 of those, that was the case. So there's variability like everything in the human body, but in the vast majority of the cases, that whole lumbar plexus is going to be situated inside the psoas. And then all the nerves that are coming from the lumbar plexus are going to penetrate through the psoas. So we can kind of look at that here. If we go back to the right side, we can look at the topmost nerve that doesn't actually penetrate through the psoas because it's not part of the lumbar plexus. That's the subcostal nerve. It does share with the lumbar plexus, but then it wraps around the body, innervates some of the abdominal muscles and the skin kind of the abdomen. Then below that, we have the iliohypogastric and the ilioinguinal nerves. Those do actually penetrate right through the psoas because they're coming from that lumbar plexus. So then they exit the psoas in those upper kind of proximal fibers of the psoas. If we continue down from there, we have the lateral femoral cutaneous nerve. So it exits the psoas a little bit more distal, a little bit more in the inferior portion of the fibers. If we go a little bit medial, you can see penetrating right through the psoas is the genitofemoral nerve. And then if we go actually medial to the psoas in that area, we'd have to kind of pick it out, but there's the obturator nerve. So all of those have a relationship with the psoas in the sense that they're all coming from the lumbar plexus. They all, pierce the psoas and exit the psoas. And they have, again, this intimate relationship with the psoas muscle. So we'll get into that later and the importance of that. There's a lot of importance just thinking about the anatomy. I'm sure you can think of many cases and pain patterns, trigger point referral patterns, how all of that is tied together and makes the psoas such a prominent structure and creating its own pain in the body, but also contributing to various pain syndromes like maybe thoracolumbar junction syndrome, involvement with clineal nerves, which are also coming from this lumbar plexus, but they're on the posterior part, not visible from this image. There's a whole bunch of pain patterns. A brief sidestep on this. This is not directly about the psoas, but for those who are really into channel relationships, my interpretation of the daimai is really these nerves that wrap around, like those subcostal nerves, the iliohypogastric, ilioinguinal, lateral femoral cutaneous nerves, those nerves that are wrapping around from the back lumbar plexus and wrapping around the abdomen. I think that speaks a little bit to the daimai. I don't know if I would say that the daimai equals those nerves, but those nerves are part of the physiology of the daimai, because those nerves also innervate the abdominal muscles like the transverse abdominis and the obliques. Those nerves are influenced, as we know, by gallbladder 41. The oblique muscles are part of the gallbladder sinew channel. So I think somehow regulating tension through gallbladder 41 has an effect on those nerves that really wrap around following the trajectory of the daimai. One other little thing about this that's quite interesting is that you might have to go back and look this up if you haven't looked at it for a while, but the kidney divergent channel intersects with the daimai at L2. That's just how it's classically described, intersects at the daimai. And if you look at the trajectory of the obturator nerve, this other nerve of the lumbar plexus, that obturator nerve goes right down and has sensory fibers right down to almost like the kidney 10 region. And that's where the kidney divergent channel takes off, kind of from that popliteal region, comes up the thigh, and then meets and intersects at the daimai at L2 region. So I think when we're looking at the daimai, we're looking somewhat at the physiology of the lumbar plexus and the psoas as kind of part of that relationship. But a little bit more of a different subject. Maybe another day we can hash that out a little bit more. But since we're looking at this anatomy, it's worth taking a moment to kind of compare and look at that kind of comparative anatomy between Western and Eastern. All right, so some other ways that the psoas interacts with the anatomy around it. Again, let's get our orientation straight from this Netter image. On the right of the specimen, the psoas has been cut. So if you look closely, you'll see the proximal fibers where it's cut. And if you follow down, you might even see the distal fibers. That's kind of right over the iliacus. Yeah, they're right there. So again, that's so we can see what's deep to that. We can see the quadratus lumborum. So the psoas and the quadratus lumborum have a pretty close relationship, the quadratus lumborum being a little bit more posterior. It takes off from the iliac crest and then goes up to the 12th rib. So there we have the quadratus lumborum, a really important muscle. We could do a class on the quadratus lumborum. It's also really quite a important structure, and maybe someday that'll be a subject of one of these webinars. I do want to highlight that anatomy because we have a dissection video coming up that is on the psoas, and that's why I put it on here, but it does also cover the QL. Because if you look just distal to the quadratus lumborum on the right, you can see how it shares fibers into the iliacus muscle, which is in that kind of pelvic bowl. And then that iliacus muscle, like we looked at that common attachment on the lesser trochanter, really forms a continuous myofascial plane all the way down to the adductors. You'll see this in another image coming up, and I'll highlight it again. But that, in our interpretation in sports medicine acupuncture, is part of the liver sinew channel. You wouldn't think of the quadratus lumborum as being part of the liver channel, because in some ways you have to needle it from the back, but it's not really a back muscle. It's a core. It's a central muscle. It's really a yin muscle on the inside of the body. Of the medial thigh from the adductors, but then it blends in at the spinal attachments that we looked at, and it really then becomes part of the kidney sinew channel, which is interesting because not only is it part of the kidney sinew channel, but we can see that the kidney organ is right up against that psoas. And in visceral osteopathy, they talk about how that psoas moves along the rails of the psoas. You know, if you kind of picture the psoas as being rails of a train track, you know, the kidney moves along the psoas. The fascia is really intimately related with the psoas, the renal fascia and the psoas muscle. And by moves, what I mean is every time you take a breath, that psoas moves about 2 centimeters down as the diaphragm descends. It pushes the abdominal contents, including the kidneys, all the organs, liver, all of that. But in this case, the kidney itself, it moves along, it kind of follows along that rail of the psoas. So if you think about how many breaths you take every day, I don't have the exact figure. This is something that I wish Matt was here because he does know this one because I heard him say it recently. But it's quite a large amount of distance that kidney travels. 2 centimeters isn't that far, but 2 centimeters every several seconds all day, that's a lot of territory. So what happens now if the renal fascia and the psoas fascia are all adhered to each other and there's limited capacity for that kidney to descend? Well, then we're going to have, you know, maybe restrictions in the psoas, restrictions in the hip flexion. We're going to have inability for the diaphragm to descend. You know, it's going to cause some kind of obstruction, some kind of congestion that's going to cause some health issues. So when you're working with the psoas, I think what I would take home from that relationship is when you're working with the psoas, to some degree, you're working with the kidney. If there's more movement and more movement potential in the psoas, there's more movement potential in the kidneys. And one of the ways that the kidneys become ill, and I don't mean like kidney disease in a Western standpoint, but in terms of lack of function, is that they start to lose that mobility and motility of the organ kind of moving along the psoas, and then that can maybe descend a little bit. It can put pressure on those nerves we were looking at. It can cause their own symptomology. So being able to free up this region can really both improve function in the hip muscles, but also in the internal organs. The other thing that we can highlight, if we go back to the right side, we can see that proximal part of the psoas that's cut. We can see how intimately related that is with the diaphragm. So that's the cut portion, yeah, right there. So in this nice clean Netter image where they take off all the fascia, you can see that it touches it, but in a real dissection with the fascia intact, you can see how integrated those fascial components are, and they become really one and the same. Those sort of feet, the crua of the diaphragm, the extensions and attachments of the diaphragm with the proximal psoas. So when you get people who are posterior tilters of the rib cage, maybe their pelvis slides forward and the rib cage tilts back, and it compresses that region of the diaphragm on the psoas, that can have implications in breathing. I'm already thinking of kidney not grasping lung qi is one way that I see it manifest. So it's gonna decrease the ability of the diaphragm to descend, but it also can actually turn off the psoas and cause problems with the psoas' ability to stabilize the spine. So when you start getting patients who maybe have back pain after starting to run, or they're out dancing, moving, and the back pain comes on maybe 5 minutes as they start to tax their breathing, that's one to start thinking of that relationship. And we have ways that we work on that in sports medicine acupuncture. Unfortunately, it won't be in this webinar, but we'll look at some ways that would affect it also. So kidney, psoas, QL, those are all, and diaphragm, those are all pretty intimately related. So let's go into the next image, or next slide. So here's the image I put together for the Sinew channel relationships. So we've already talked about them. I don't think I need to spend a whole ton of time saying it again, but we can see it from a different capacity now. So we have that medial thigh with the adductors, especially adductor longus brevis and pectineus. Gracilis could also be included in that. These are part of the liver sinew channel. For those who know anatomy pretty well, the posterior muscle of this adductor group, adductor magnus, attaches to a different portion on the back of the femur. It's in a little bit different region. It's a little more posterior than this group. That would be part of the kidney sinew channel. So we're looking at the thigh portion. We're looking at the liver sinew channel as it comes up to medial thigh. And you can see both the iliacus and the psoas, the iliopsoas, is part of that liver sinew channel coming from distal going up into the body. We talked about the iliacus and the QL. You can kind of find that in this image. It's marked on the right, QL iliacus. That's following that liver sinew channel all the way to the 12th rib. And then the psoas starts to attach more into the bodies of the vertebra, blends in with the anterior longitudinal ligament, and it becomes part of the kidney sinew channel. So the psoas is kind of a crossover. It takes off distally from the liver sinew channel, and it ties into the kidney sinew channel. So which is it? Well, we talk about it a couple different ways. When you're working with the distal iliopsoas for like groin strains, then more often than not, there's direct needling you can do, of course, but if you're using distal points, it's going to be liver channel points that are going to have more of an effect on it. Liver 4, liver 5, those types of points are going to have a stronger effect on that. Liver 5 is going to have a really strong effect on the quadratus lumborum through that QL iliacus relationship, but it would also have an effect on the distal iliopsoas. So really, when you're talking about that distal portion as it comes over the iliopectineal ridge and then goes down to attach to the femur, you can kind of think of that as liver territory, liver sinew channel territory. As it dives deep into the body, and we're talking more about stabilization of the lumbar spine, we're talking about how that stabilizes and moves and supports the lumbar spine. Then I'm going to put on my kidney sinew channel hat and think about its role more from the kidney sinew channel and how that's going to affect it. We will look in this webinar at a way of affecting that relationship when it's not stabilizing the spine and if the psoas is sort of testing weak. But if I were going to use distal points, I might start thinking more kidney points. Kidney 7, the tonification point on the kidney channel, can sometimes wake up that ability for the psoas to support the lumbar spine. So if you're thinking more body of the psoas, I guess you could say kidney. If you're thinking more distal iliopsoas, you can think liver sinew channel. I can say it a different way, that if I'm thinking excess, I tend to see more of a relationship with the liver sinew channel. Excess meaning hypertonic, restrictive. When I start seeing situations where it's more about stability and support, then I see more of a relationship with the kidney channel, kidney sinew channel points distally. So that's a way of kind of making sense of its roles in terms of these two channels that it connects with. All right, so actions of the psoas. The psoas does hip and trunk flexion. Hip flexion, of course, we think about that with walking. Trunk flexion I want to come back to in a couple slides, so just kind of put a little asterisk by that one. It does lateral rotation of the hip, unless you see a source that says it does medial rotation of the hip. Lateral rotation is the bigger consensus, but I think its rotation on the hip is negligible. I don't really think about it so much personally, unless I'm doing a manual muscle test. And you'll see in the image coming up for that there is a slight lateral rotation, but I don't think it has a real large role in terms of lateral or medial rotation of the hip. And sources say different things about it. So maybe it varies depending on the person's position and how their body's structure is. Hip flexion, definitely. Trunk flexion, definitely. This third bullet point, also definitely. Lateral flexion of the spine and contralateral rotation. So if you can kind of picture that psoas contracting on one side, it's going to side bend that spine into a lateral flexion to that side and rotate it away. Okay, so let's think then about that. The psoas could be shortened. It can contract and shorten. It can contract and shorten in movement, hip flexion and all that. But if it's chronically hypertonic, it's going to pull on the lumbar spine. It's going to, and this is the consensus, it's going to pull it into more of a excessive lordotic curve. It doesn't attach directly to the pelvis, but in the process of that spine being pulled into a lordotic curve and exaggerating that hyperextension of the spine, as it pulls the spine closer to the lesser trochanter, it's going to pull the pelvis into an anterior tilt. So that top image is showing a neutral pelvis. Matt has a measurement at the ASIS, and then in the front, and then a PSIS in the back, and there's about a 1/4 inch, maybe about a finger width between that. So that's the measurement for a normal, kind of a neutral pelvis. It's about a 1/4 inch higher in the back. That's normal. But in the lower picture, you can see now that that 1/4 inch is greater than a 1/4 inch. That ASIS is situated much lower than what you see in the top image. So that's what you would start seeing with bilateral shortness or unilateral if we're just looking at it from one side. But let's imagine that the pelvis is bilaterally in that anterior tilt. That same measurement he's doing on the right would look very similar on the left. This measurement, takes a little practice. You have to be right at the center of the PSIS. You have to find the upper border. You have to find the lower border, kind of find the lateral and medial border and get right in the center of it. And then the highest part also of the ASIS, and that's going to give you the measurement. Because you could kind of picture if I'm at the top border of the, geez, looks like I'm in mirror image here. I'm going to change my hand around and see if I don't know if you guys are seeing the same thing I am. If I'm at the top border of the PSIS and the lower border of the ASIS, it's going to give me a false read. I need to be in a very consistent place. And that would be at the peak, the central aspect of the PSIS and the ASIS. And that's going to give me a sort of a more accurate measurement. But that's how you would measure it. But, just looking at it, if you just look at that lower image, you can see that there's a greater inclination forward, anterior tilt of that bottom image. So if that was that way on both sides, then I would be thinking that the psoas is in a locked short position bilaterally, pulling that spine into an excessive lordotic curve, taking the pelvis with it into an anterior tilt. Sometimes looks like the person can't fully stand up. Picture them seated, their hips flexed, they go to stand up, and it's like as if that last few degrees of hip extension isn't there, and they're kind of held into hip flexion. And their spine tends to be a little bit more arched. This is the consensus with shortening of the psoas, at least bilaterally. Tom Myers has an interesting perspective on it that I do kind of think there's some merit to this. And he looks at the upper fibers versus the lower fibers. So when you remember back to those images we were talking about the anatomy, it's almost like 6 muscles, right? From L5 all the way to T12. I did a dissection at University of Tampa with a physician assistant group where for the students, for the physician assistants, and I was helping lead the kind of group of dissections. And one of the specimens had really severe scoliosis. And the lumbar spine almost became horizontal. And you could really see on that side those 6 individual slips of the muscle as they kind of widened that whole aspect of the psoas. And you'd see each of those little slips going and attaching to the various attachment sites on the spine. And with that spine orientation change, it kind of widened the whole psoas and almost gave that appearance of these 6 muscles. So if you think of that way, those upper fibers, the ones that are accessible more laterally, are the ones that go up higher on the T12 L1 region. If those are shortened, like in that upper picture on the right, that might actually pull the spine more into a straightened kind of curve, as if the person is on the floor doing trunk flexion like a curl, which the psoas would be involved with. I would say that in that case, it's more the upper fibers. Whereas the lower fibers in that bottom right image, and kind of drawing, that's really showing more of the lower fibers pulling the spine into a hyperlordotic curve. I think this plays out quite a bit, especially when you get people whose pelvis is shifted forward and the rib cage is shifted back. Sometimes those upper fibers are the more involved ones. So you can almost see the psoas as being an antagonist of itself, upper fibers versus lower fibers. This is not the normal view. This is not the consensus. This is an alternate view, but I kind of like this view, and it kind of does give me some suggestions of how I work, especially with manual therapy. Unilateral shortening, like we mentioned, is going to pull the spine into lateral flexion to that side. And contralateral rotation, when you're looking at somebody, the umbilicus will look like it's pointing away from the short psoas. So that's a simple way of looking at it. You can kind of see the umbilicus saying, I'm pointing away from it. So the direction it's pointing to would be more of the lengthened psoas. The direction it's pointing away from would be the shortened psoas. There's a lot of things that can affect the the umbilicus position. There could be scar tissue there. So I don't take that too literally. That's not an exact way, but you can sometimes come over the person and look down the spine, and you can see that lumbar spine rotating one way or the other. So the side that's more posterior is going to be the lengthened side, and the side that's more anterior is going to be the shortened side. We'll look at another way to address this in a second. All right, so we have a cadaver video coming up. I just want to remind people who've seen some webinars where we have cadaver videos that these are, shouldn't be kind of viewed in public. If you're at Starbucks right now and there's somebody who can see your screen, maybe it'd be good to not watch this now, come back and watch it later. Just be mindful of your surroundings. This one, no faces are shown, but this one is pretty internal, and I think it could be disturbing for people who aren't medical professionals. If you find this stuff kind of disturbing, maybe don't watch, but especially be mindful of your surroundings. Don't take screenshots. Don't share these, don't record and share these videos. We have to be really respectful for the donors. This is for medical professionals. So just have that caveat when you're watching it. And let's go ahead and look at this. It's going to show the psoas. It's going to show that QL and iliacus relationship and some movement.
So one last aspect with the psoas is we can look at the different fibers, medial versus lateral, and how that relates to the lumbar spine. So if I look at these medial fibers, the medial fibers are going to be attaching to L5 and L4 in the lower portion, but the more lateral I go, the higher up the fibers become. So the fibers that are going up to T12, L1, upper portion, are going to be the lateral fibers, and the ones that are going to the lower lumbar spine are going to be the medial fibers. So there's some indications and some viewpoints on this that the medial fibers would be more involved with an anterior tilt and with lordosis, as they would be pulling the lumbar spine into a hyperlordotic position, pulling the L5, L4, L3 lower portions into lordosis, versus a posterior tilt where maybe the T12 L1 portion could be putting the lateral fibers, the more upper fibers, into a shortened position. It's not the common view, it's just an alternate view, but interesting to think, since the muscle is multiple slips, that this could be both involved in an anterior and posterior tilt, depending on which fibers you're looking at. Especially relevant for manual work because we could highlight the different fibers. Last thing we can look at, since we've talked about the quadratus lumborum, is we get a good view of the quadratus lumborum now coming to the medial portion of the iliac crest and joining fascially, at least. The fascia has been taken off, but you can see the same fascial plane in through the iliacus, and then of course down into the liver channel as it travels and meets with the fascia of the adductors. As I go up from there, The diaphragm has been removed during the evisceration process, or at least disturbed, but we can appreciate that that same fascial plane then would blend into the crus, or the feet of the diaphragm, from the upper fibers of the QL. And of course, the psoas itself would be very integrated with the upper fibers of the diaphragm.
Actually, Alan, I think there was a little bit more of that video. I wonder if we can go back and slide forward a little bit. If we can't do this, it's no big deal. Instead of watching the whole thing, I don't know if this can be jumped to about the middle.
Unfortunately, Brian, we can't
Okay.
advance it.
Yeah, no worries.
Sorry about
No worries. Yeah, no worries. Okay, so let's go to the next slide. This one just shows some of the, like, I kind of move the rib cage, and you can see the psoas like side bending the spine. But I think we got a pretty clear idea with that just by description. So this test here is lumbopelvic rhythm. This we look more at for the urinary bladder channel relationships in U channel. It's looking at the normal position where the lumbar spine moves in a one-to-one relationship with the innominate bone. In the middle one, it's showing that the innominate bone is not moving. So you're getting all movement in the lumbar spine, showing a restriction in the hamstrings. In the farthest right one, the innominate bone is moving, but the lumbar spine not. So more of that restriction in the urinary bladder sinew channel at the level of the lumbars. Why am I showing it here? Because after we do this test, we can go to the next slide and we can have the person facing away from us, and we can look at them from the back. And if you look at that image, and I'll let you look at it for a minute, from the back, can you see that one side is up higher? And by one side, I mean the lumbar spine is up higher than the other side. So going back to that information of what the unilateral imbalance does at the psoas, that raised side is going to show us the likely locked long inhibited psoas, whereas the locked short psoas is going to be, on this case, on the right side, which is pulling that excessively into rotation, or the left side is failing to support the spine. Which is it? Is this excess or deficient? Excess on the right, deficient on the left in relationship to each other. But on any given person, then we have to figure out, is this more about that excess, more about the deficiency, or both? But at least it's telling us there's an imbalance there. So this lumbopelvic rhythm, great test for the urinary bladder sinew channel, but we can look at it from the back and get a window into the kidney sinew channel. So we have that left side showing that a relative lengthened position compared to the right side. And we can take that right into a manual muscle test. Manual muscle test of the psoas is having the hip in about 35 to 40 degrees flexion. That image is showing a little bit more than that. I think I put the wrong image in that. I noticed this just before we went live. This looks like the iliacus manual muscle test. So imagine that same position, but a little less hip flexion. Yeah, about that angle of hip flexion. So they look alike, and I just grabbed the wrong one. But psoas manual muscle test, everything else would be approximately the same, but it's more of that 35 to 40 degrees of abduction. Of flexion, and then abduction to about 35 degrees, driving UB58 back towards the table. So you're taking them in slight abduction, but really focusing on the extension, and the psoas is called on to support that. So that is the manual muscle test of the psoas. You could do that immediately after the seeing that sign, that psoas sign in the previous test, or you might do this on its own. But this is going to give you a window into how those psoases are supporting the body. You have the person, you kind of give an initial load, and as you overpressure the psoas, you're seeing if that psoas fibers has enough chi to lock on. We'll talk about GB27 in a second. That's probably what we'll close with. But you could also try even just putting a point in something like kidney 7 and seeing if that wakes up. You might have to draw the needle back before you test, and then retest and see if there's a little bit more strength in the psoas. Kidney 27 will definitely do it, but you can also look for other points like kidney 7, kidney 3, kidney 6, other channel points that might affect it. I'm not going to talk about 62 and SI3. That is a little bit longer of a discussion. Let's go then to the next slide. So that goes into treatment. We have motor points that lie deep to UB24 and UB25. I'm not going to go into the needle technique for these because they involve a pretty deep needle technique that really takes some time to talk about. And we'll allude to it, but it's really something that needs to be spent a lot more time for safety reasons. But you can needle the psoas directly from the back. There's these two motor points. They lie deep to UB24 and UB25. The position is going into the next slide, is through the back. There's a needle technique that kind of follows the edge of the iliocostalis lumborum muscle and goes along the lateral raphe right to the psoas. It's safe if it's done properly, but to go through all the details in such a quick class like this would be a little bit irresponsible, because this one can cause damage because it's a fairly deep technique and there's some complications. The person can go into reflexive spasm. You just have to be aware of some things before doing it. This would be, though, useful for the excess side particularly. So it is one to consider learning at some point. But the next one is can affect the psoas actually quite well, especially for the locked, long, inhibited psoas. This is a technique that Matt came up with years and years ago and has used and taught, and a lot of people have used it quite successfully for a long time. And this is using gallbladder 27. So with gallbladder 27, you're angling it slightly lateral and with like a slow sort of in and out green turtle searching for the point needle technique until you get either one of the following sensations, either wrapping back around the daimai, wrapping down towards the liver channel, towards the groin, or following the stomach channel down the side of the leg, affecting either the lateral femoral cutaneous nerve down the stomach channel, the iliohypogastric nerve going towards the groin, or the ilioinguinal nerve wrapping around. Maybe I think I have that back. Iliohypogastric wrapping around the daimai, ilioinguinal wrapping to the groin. But it's affecting one of those nerves from the lumbar plexus, which is going to reflexively turn back the psoas on, kind of stimulate that same neurology, because it's also innervated by that lumbar plexus, and turn that psoas back on. So it doesn't have to be a strong sensation, but you need one of those three sensations. And that will kind of calm down a locked short psoas, but this technique really shines for the locked long inhibited psoas. Right? And I think I wasn't sure timing if we would have time to show a manual technique, but I think we have a little bit of time. It's not real long, so let's go ahead and go into that, because I think this will bring it together. This is from a blog post we just came out in October, so it's on Sports Medicine Acupuncture. If you're looking at this webinar later on, it's the October post. You don't need to know that. You can just find it, do a search for it, or find it. But it's called Working with the Psoas, and it goes into this technique, a little bit of setup, but then into this technique a little bit more in depth. This technique is also on our YouTube channel, this video you're about to see. So you can access it there if you wanted to review it later, or of course it'll be in the recording for this class. So quick setup, and then we'll look at the video. I'm working on both sides at the same time. It's a very integrative technique. I'm going to do a movement that simulates walking. And then as simply, I could say I'm pinning down the psoas and just letting that kind of free up each side. But really, I can do more than that. I can kind of nudge, maybe a psoas that's really narrow and pulled medial, I can nudge it more wider. I can kind of work on those medial fibers and nudge it out a little bit. I can nudge the wider side more medial, and kind of even that out that way. So depending on which fibers are short, I can kind of affect it. I can feel when I'm in there that one psoas is going to be much more medial. That's going to be probably the locked kind of short side, and the way it kind of changes the orientation of that psoas. The other thing is when the person presses their foot, this movement you're going to see in a second, and lifts the other foot, there's sort of a down on the foot they press, there's sort of a downward movement and an upward movement on the foot they lift. And you can feel if those are even, and I can nudge it down or nudge it up. So I can kind of look for an even movement of the psoas. But what I'm really doing is using the psoas as puppet strings to sort of mobilize and get an even rotational movement in the lumbar spine and all the way through the pelvis. So simply, I can just hold it down and kind of free, or I can influence movement. I can kind of mobilize in various directions. I kind of say this in the video, but I don't think I go quite into as much detail. So let's go ahead and look at the video.
So we're going to do a psoas technique. This one is going to be working on both sides, left and right, at the same time. It's very much of an integrative technique. because we're trying to sort of get an even tone between the two sides, but also an even movement. So let's look at the movement aspect first. The patient is going to slowly lift one foot up. At least they're going to lift the weight up. They might not actually lift the foot off the table, but they're going to start to bring the weight off that foot while they push the weight into the other foot. It's like a walking motion. There you go. You don't have to actually lift the foot up. It's more about the pushing foot than it is about the lifting foot. So they don't have to literally lift it off the table. There you go. Now decrease that movement by about 50%. There you go. Yeah, so it's a small movement. So she's starting to do a movement that's very much like walking. So when I'm in working on the psoas at the time, I'll be able to feel the movement that's happening associated with the psoas. I'll be able to feel the tone of the psoas, but also the rotation aspect that's happening in the spine and through that area to the sacrum. So go ahead and relax. I'm going to find the ASIS. I'm going to start following the slope of the iliacus muscle to be able to get down to the depth of the psoas. So it's like you're kind of going into a slope going medial, which will take you right to the iliopsoas. I can move a little bit medial, moving any visceral or neurovascular tissue off to the side. And now I feel like I'm at the depth of the psoas. Before she does the movement, I want her to lift. Go ahead and lift your left foot. Relax. So I can just fine tune where I want my pressure. Lift the left foot again. There we go. Good. Now I'm right on the psoas on the left. I'm going to go ahead and lift the right side. Right side already feels like there's a little bit more tone. Okay, so now I'm on the psoas on either side. So start slowly doing that movement. It doesn't have to be a big movement. It's just about encouraging an alternating contraction with the psoas. And I can do two things. I can soften the right side, but I can also follow that rotation and help try to get an even movement to where it kind of sinks more easily on the left side. Right side feels like it doesn't want to go, but I can follow it into that movement. And just wait for the tissue to sort of normalize and feel a little bit more similar between the two sides. There we go. Now it's starting to move, starting to soften a little bit too. Doing okay? Definitely want to work respectfully with the psoas because it's very sensitive and you want to take your time and not bully through the tissue. You might also, with this one, find that you work a little bit more on the medial aspect of the psoas on one side and the lateral aspect on the other, which I'm doing on the right side. I'm hooking into that medial aspect and helping bring it lateral. There we go. One more time. That's good. Okay, now I'm just going to hold and just have her just do that movement a little bit. I'm not going to do so much this time, just to let the body function normalize a little bit.
All right. So that is it. Here's some references if you want to go back and look at any of those just from the presentation. But I think that is the presentation for today. If you wanted to look at that blog post, it goes into that last technique a little bit more in depth. And like I said, hopefully by the new year, we'll have a 3-hour class. We'll be able to go through a little bit more of the needling and more comprehensive. But I think hopefully this is something you can use right from the get-go. So Lauren Brown is going to be here next week. So tune in for that. And thanks again to the American Acupuncture Council for having us, and look forward to seeing you guys next time.